start showing you how, you know, we come to a point where we can call, as you know, or as you can imagine, we can almost call the use of cesarean section a epidemic. This graph shows how the cesarean section rates have been increasing for the last 3 decades in the world. So each line represents one region, and we see here the Latin America and the Caribbean region as the all-time winner. And Oceania, North America, also high cesarean section rates. Europe in green, above 20%. You have there a bar in gray that shows the historical 10 to 15% cesarean section rate that has been historically used as a reference. So we have, you know, we are facing a situation where there is a growing number of countries in the world where what once was a rare procedure now is used to give birth by even more than half of the population. This is a big change from the population perspective. And how do we see the future? Well, the future, WHO conducted projections and predictions, and the future shows no change. So predictions for 2030, as you see there, show continued increase on the use of cesarean section throughout the different regions. Each graph of those represents a region in the world. And for those of you who voted that, yes, you would support the implementation of interventions, but you thought it was very difficult, I guess you're right. The projections show how difficult that would be. In terms of Asia, the region, you know, your region where Myanmar is, we see, you know, that Eastern Asia, 63% of births by cesarean section in 2030 would be expected if things go as they go, or as they look, you know, are going to continue going, and no interventions are implemented. Myanmar is in the southeastern Eastern Asia, and it is expected in this region. This is not a particular prediction for Myanmar. This is a prediction for the southeastern Asia of 25%. We know that that's an average, and there are large differences between countries. So on one hand, for example, we have countries with very low cesarean section rates, according to the latest estimates of WHO, countries with less than 2% cesarean section rates, with showing clearly that women may die in these countries because of lack of access to a cesarean section. On the other hand, we have countries with very, very high cesarean section rates. I was saying before, you know, more than half of the population gives birth by cesarean section. I wasn't exaggerating. These are countries that with around 50% cesarean section rates. The latest estimates from WHO suggest that about 17% of women give birth in Myanmar by cesarean section, although this is a old, or you know, estimate for 2014. We also know that overuse and underuse of cesarean section coexist even in the same districts. And this graph shows for those countries at the bottom how the cesarean section rates varies according to the economic status of the women. And to take Bangladesh as an example, we see, and we can interpret in this graph, that while the poorest women, shown with the dot in white, have a cesarean section rate of 5%, the richest women have a cesarean section rate of 47%. So with that, against this background, and going back a little bit back in time, we remember that in 1985, WHO issued a statement that said there is no justification for any region to have a cesarean section rate higher than 10 to 15%. This was back in 1985, as I said, and obviously things have changed a lot in the last 3 or 4 decades. So WHO in 2015 started working, well, it started before, but in 2015, issued a new statement, a WHO statement on cesarean section rates that superseded the previous statement. And this work done by WHO came to the conclusion that there is no ideal cesarean section rate that we can promote across the countries or across the hospitals. And WHO doesn't promote any specific rate as ideal, but promotes that every effort is made to provide cesarean sections to all women in need, rather than striving to achieve a specific rate. So we're moving away from specific rates into ensure that all women that need a cesarean section have access to one. And in the same statement, WHO recommends the use of the Robson classification system as a standard to monitor, compare, and assess cesarean section rates. And in the second presentation of this afternoon, Dr. Robson will be presenting the Robson classification system. So I don't need to go in detail, but just to share with you that this is a system that classifies women, not cesarean sections. This is a big change from what we've seen before. Classifies women according to a few variables that are normally and routinely collected. So it's a very easy system to implement. WHO, after the recommendation to use the Robson classification, WHO produced the Robson classification implementation manual that helps understand the classification and explains how to implement it. Since this was endorsed by WHO, but even before, the classification is used worldwide. Very largely, more and more countries are endorsing the classification. Currently, we know that more than 70 countries worldwide at some level are using it. In supporting countries to the use of the classification, WHO also created the WHO Robson platform, the Robson classification platform, and we'll talk about later. But just so you know, it aims to promote quality of care during childbirth by improving understanding of the use of cesarean section. And the platform facilitates global sharing of data using the Robson classification. So this is a platform that is used at hospital level. So it's a tool for hospitals. And it helps you as a hospital obstetrician or as a hospital midwife, visualize your data as the Robson classification, it helps you to create graphs, charts, assess your rates, your practice and trends. It helps you identify or allows you identify maternity units or hospitals worldwide with specific characteristics on cesarean section rates that you can start dialogue. You can contact them and you can start a dialogue to promote and to understand their cesarean section rates, promote clinical practice discussions between healthcare professionals and providers across the world. But what happened with cesarean section? Why are cesarean section rates growing so rapidly? This schematic representation, this figure published back in 2018 in Lancet, is a good scheme to understand factors that affect the use of cesarean section. The use of cesarean section is affected by multiple factors with multiple stakeholders, and this figure actually shows the different stakeholders. So if we start quickly by trying to understand these factors, we can start by the obstetric factors, which are represented in this figure at the center. These are factors that have to do with medical condition, obstetrical conditions, like obstructive labor, breech, presentation, transverse lies. Those are medical factors. Then we have the next layer of factors are related to the women, families, and communities. And these factors, for example, are experiences in the previous birth, bad experiences in the previous birth that may make women to not want to go through birth again, the choices available, the fear and anxiety that a woman may develop facing birth, the emotional support that women have access to, for example. Those are factors that are going to affect the cesarean section rate. Moving to the next level, we have the factors related to health professionals. And here we have factors like the fear of blame, of the fear of loss of reputation, including medical and legal concerns. Here we have also beliefs about the beliefs about the women that doctors may have, the convenience, how the doctors see the convenience of being able to set up a cesarean section at a convenient time, the education and training available at the hospital level, and there we have the assisted vaginal birth issue, and many others, as you can see in the figure. Last, we have the set of factors related to the organization, systems, and facilities. And here, just to mention some, we have the culture of intervention, the ethos of intervention that a hospital may have, the commitment that the hospital has to normal birth or to following and endorsing evidence-based practices, the logistics, the financial, we talked financial structures before. All those are factors that are going to affect the possibility of the doctors to decide on a cesarean section or on a vaginal birth. So, and one of the things that is interesting about this graph is that it shows how there are clinical and non-clinical factors associated with the use of cesarean section. So we're talking about factors that go beyond the labor ward. And this is important because we see how we need to expand our interventions beyond the labor ward in order to be able to tackle this challenge. Just a couple quotes from qualitative research that are very telling on the factors that affect the use of cesarean section. This quote is from a woman in Thailand, and it says, "Now there are many media on the internet, so many people view that cesarean section is normal. Most of my friends choose a cesarean because they could control their baby's destiny, deciding on an auspicious day and time for the birth. Shows clearly this has nothing to do with the labor ward. These are the cesarean sections that probably are taken before the woman comes to the hospital." And a second quote from an obstetrician in Iran: "If a patient sues us for any reason, the first thing they ask is why you didn't do a cesarean section. There is no positive feedback or encouragement for vaginal delivery. I had vaginal delivery for a 4,700 grams baby. Nobody cares. Nobody says thank you." So again, this speaks to those that said, yes, we would support reducing cesarean section, but it's too difficult. So against this background, and again, remembering that the decision for cesarean section may come much earlier than the woman comes to the hospital, or maybe taken, earlier than the woman comes to the hospital, and definitely earlier than the labor ward, WHO in 2018 issued recommendations on non-clinical interventions to reduce unnecessary cesarean section, which were also published in Lancet. So WHO proposes 5 recommendations, and we have one recommendation. You remember the levels, the different levels of factors in the previous graph: women level, healthcare providers level, and health systems level. So WHO has 5 recommendations. 1 is at women's level, 2 are at healthcare providers level, and 2 are at health systems level. So let's start with the first one. First one, WHO promotes or recommends educational interventions that engage women actively in planning for their birth. Interventions or educations that give women agencies. These could be childbirth preparation workshops, relaxation programs, or psychosocial support for those women with fear of pain or anxiety. And these interventions should be implemented with ongoing monitoring and evaluation. The as is recommended by WHO. So if these interventions are targeted at women, it is very important to understand what women's views are about these interventions. What is the women's opinion? Because that will maximize the adaptation and the success in implementation. So the recommendations of WHO are based in rigorous research and assessment of effectiveness, but they are also based, or they take into the consideration women's views. And what do women have to say here? What do women want? So we learn in doing research that women think that learning new information about birth is empowering. And therefore, they want educational tools like childbirth training workshops or booklets, decision aids. So women actually welcome tools, and in multiple formats, whether it's a video, whether it's through Instagram, whether it's a pamphlet, but they also say that the information on paper is ultimately needed for reflection with family, friends, and healthcare providers. So they want a booklet or a paper that they can take back home for discussion in the family. The content of the educational materials should not provoke anxiety. So it's not about telling them how risky labor is. That's not what they want. And the content needs to be consistent with the advice provided by the healthcare professional. We need to be careful that we are all aligned and not giving contradictory messages. And it needs to provide the basis for more informed dialogue with the healthcare provider. Lastly, we learned that women want emotional support alongside the communication of facts and figures. So then we went one step forward to look into what makes an intervention targeted women successful. In other words, what are the common features that interventions that have been successful have in common? And what we learned is that we found that provision of support to women is actually critical and makes any intervention targeting women more likely to succeed. And how do we implement this support? So we found that interventions that are more successful provide communication materials to women on birth-related information. So communication is essential. They also encourage emotional support by partner or family participation in the activities. Also, support or peer support through group-based intervention delivery. So when the educational intervention is provided through group-based, this also increases the likelihood for success. And lastly, we have to give women the opportunities to interact with healthcare providers. So to maximize the benefits of interventions targeting women, these 4 characteristics are recommended to be implemented. So going back to our 5 interventions that WHO recommend, we already touched upon the educational interventions for women. We're moving into the 2 recommendations for healthcare providers. Here we have the implementation of evidence-based clinical guidelines. And this is something that you, in the Mentimeter, a large majority of yours already said it would make a difference. So evidence-based clinical guidelines with a requirement for a second medical opinion when in settings where this is possible. So second medical opinion means before doing a cesarean section, you consult with another doctor. This second part, you didn't think it was that useful back in the Mentimeter. The third intervention targeting healthcare providers is same evidence-based clinical guidelines, implementing evidence-based clinical guidelines, but this time is performing regular audits of cesarean section at the healthcare facility, providing timely feedback on the results of those audits to healthcare providers. And then moving into the two interventions recommended by WHO, which target health systems. We have the first one, a collaborative midwifery obstetrician model of care, which means that a model in which the care is provided primarily by midwives, but with a 24-hour on-site backup support from a dedicated obstetrician. And the fifth is financial strategies for healthcare providers or organizations. And here there are financial strategies as the insurance reforms or different payment methods for healthcare organizations, or even legislative imposed clinical or practice guidelines. For these two last recommendations, WHO recommends under rigorous research. So the interesting fact is that financial strategies are not recommended by WHO because they are effective. There is no sufficient evidence to any recommendation of that type. The issue or the challenge is that in many parts of the world, financial strategies are being implemented as if they were effective. Therefore, what WHO recommends is that if you are going to implement a financial strategy of whatever nature it is, you need to do it under rigorous research. So again, with the same interest, it's important to understand what do healthcare professionals think about these interventions targeting them. So here we learned that there is no clear consensus between healthcare professionals as to what constitutes a definite indication for cesarean section, place or parity, across time, place or parity, sorry. So against that background, professionals just draw on different evidence to support their underpinning belief about vaginal birth as a normal or as a pathological process. And the extent to which healthcare professionals value the lowering of cesarean section rates is influenced by different factors. One is fear of blame and recrimination. And we've seen this also previously in the figure of the factors. Also, the value they attach to the financial rewards associated with cesarean section. Also, the preference for a cesarean section as a convenient, efficient birth that can be scheduled and that can allow for a more structured life. And lastly, also their beliefs about women, about what women are ready for, what women are able to cope with, and if women are able to give birth vaginally. So as you see, this is very similar to our initial will or our initial figure regarding the factors. Similarly to what we did for women, we try to understand, we try to answer the question, what are the components that make intervention targeting healthcare providers more successful? What successful interventions have in common? So we learned that what is important, or the features that actually improve or increase success in interventions for healthcare providers are important. The training. Training is important to improve providers' knowledge and skills on labor management. Also, active dissemination of cesarean section indications through EIC materials and reminders. The third feature that we found that made a difference was having actionable recommendations from each audit and feedback cycle. It's not sufficient to do an audit. It's not sufficient to give the feedback. It is important to have actionable recommendations saying what it needs to be done. Multidisciplinary collaboration across cadres of healthcare workers is important, and it needs to be encouraged. And also very important is the provider's willingness to change. If there is no willing, it's going to be very difficult to make any difference for any intervention, no matter how good it is. Of course, these interventions on reducing cesarean sections are not recommended in isolation. They need to be implemented according to the needs of the country or the needs of the setting in conjunction with the WHO recommendations for the WHO recommendations for the intrapartum care for a positive childbirth experience. And just to mention, 3 of important recommendations that are worth mentioning is the respectful maternity care for women in a manner that women maintain their dignity, privacy, and confidentiality. Effective communication is also recommended for a positive childbirth experience, communication between the maternity healthcare provider and the women, using simple and culturally acceptable methods. And also, lastly, the companion of choice. Companionship is also recommended throughout labor and childbirth, and it has to be a person, the companion needs to be a person chosen by the women. It could be the spouse or the partner, female friend or relative, community member, doula, but it's important that the women's wishes are respected, including those who prefer not to have a companion. So just to summarize a few key messages to finish my presentation, the increase of cesarean section and therefore the reduction of unnecessary cesarean section is a complex challenge, and there is no simple solution. Unfortunately, we don't have a pill. We don't have a one-fits-all magic pill. It's multifactorial, as we've seen. So a single component intervention is not going to it's not going to fix it. It's not ideal. We're going to have multi-facetal, multi-component interventions. All stakeholders need to be considered in the intervention: women, families, healthcare providers, and organizations. We are all in the same boat. And if we make it, we're going to make it all together, or we won't make it. We can have interventions where they are not fitting women, or interventions that are not suitable for healthcare providers. Everybody needs to be happy with the interventions. Women need to be empowered, and meaningful and effective communication is essential. Women need to know what's happening to them, why interventions are being imposed or are needed for them. Respectful, collaborative, multidisciplinary teamwork and communication is also essential. We work in teams. We all each have our strengths and limitations, and we need to work together. Continuous professional education, training, and support is also essential to have a workforce, healthcare providers that are skilled and prepared. We also know that it's a complex challenge, but the factors that affect are different in different countries. They may be very similar, but the main drivers may be different in different countries. Therefore, it is important that before implementing any intervention, we know your setting. You have to know your setting. You have to understand what are your main drivers so you can actually address them and target them. And that's all. Thank you very much.
Hello, good morning, or good afternoon, I think, in Myanmar. I'm very privileged and delighted to be here and to join your meeting. And my job is to explain and talk to you and give you confidence about the 10-group classification system and this concept, too, of the intention to treat, both of which are worth understanding, I think. Now, I want to put this against the background of this quote, a Nobel laureate in physiology, who said very succinctly, discovery consists of seeing what everybody else has seen and thinking what nobody else has thought. And that's a good context to the 10-group classification system. At the moment, evidence-based medicine, there are two competing philosophies. There's the process-driven, very much the more popular one, represented by randomized controlled trials where you test processes, and the outcome-driven philosophy where you look at information, you routinely collect it, you classify it, and you interpret and change processes as a result of this. Now, if you look to other areas who also want to achieve quality and safety, business or professional sport, they don't depend so much on randomized controlled trials, but they have developed great improvements in routine data collection and organization of the information to make sure it is useful. And indeed, in our speciality, perinatal healthcare, the first measure of safety, quality, and consistency in any organization is knowing what your results are. And that is just routine data collection, which is quite a challenge itself. The second measure of safety, quality, and consistency is the ability to understand these results, compare them with other delivery units, and then use them to improve quality of care. And this is what I refer to as classification. But when we are looking at information, it's really important to differentiate between prospective information, which is information you know before delivery of the pregnant mother and babies, and retrospective information, which occurs after delivery or during delivery. So prospective information, the parity, the category of the pregnancy, the pathway to delivery and gestation, they're all known beforehand. They're related to pregnancy. And others, prospective information is age, BMI, and case mix. You also know those beforehand. So that can give you a prospective structure, which you can look at results below, which are retrospective, all the labor events, outcomes, interventions, complications, adverse events, and medical legal cases. And it's very important to think about the difference of those two types of information requirements. This is just a very simple cycle, quality assurance program cycle, where you put all this into context. First of all, if you're going to believe in this philosophy, you need to collect the data. There's pre-labor outcome events, there's labor and delivery outcome events, and there's post-delivery outcome events. Collecting information within an organization is a big challenge. Whether it is in the east of the world or the west of the world, wherever it is in the world, it's a big challenge. Who collects it? When is it collected? How is it collected? And why is it collected? The more information you collect, the more difficult it is. Once you've got that raw information, you need to organize that information and making it useful and describing not so much acceptable ranges, but what the ranges of outcomes events are and find explanations for them. And even if you've gone so far as collecting and understanding the information, you still need this other aspect to complete the cycle where you have an organization that can assess management, modify management as appropriate, and then continue to audit. But why is this so difficult? Why have we had trouble doing it and continually having trouble? Well, it's not recognized as an entity, a specialist area, or even at all useful. Collection of routine quality data is resource dependent, and it requires total organizational commitment, not just one person. There's no accepted classifications, principles, or training programs at the moment, but that is getting better. And few delivery units, regions, countries, and certainly no governments have actually committed to this, an organization of the information. So let's just talk a little bit more about having the principles of classifications, assuming we've managed to collect the raw data. The purpose is very important to understand. It's to convert raw data and information into useful knowledge, which will help us learn from each other and improve care. And it's trying to achieve complexity, i.e. useful knowledge, through simple, intelligent organization of raw data. In order to understand anything about what happens, especially in perinatal care, but in everyday life as well, you've got to understand the incidence. You've got to know the incidence, how often something happens. And to be able to do that, you need a definition. And once you've got the definition, you can count them, but to interpret the right percentage, you need to use the right denominator. And that's where people have gone wrong a lot of the times in the past. There's also a hierarchy of classification systems. At one end of the spectrum, you may just have raw data, completely unorganized, and unorganized information. It results in no conflict because it's just raw data. Nobody disagrees. But importantly, no useful knowledge. The other end of the spectrum, you may have very specific and organized classification of information. But it's so detailed and so specific, it's difficult to get consensus, i.e. it's difficult to get everybody to use it. So it therefore, again, doesn't become used, and we still have the same problem that there's no useful information available. And the whole idea about the 10-group classification and other classifications that I'm involved in, like indications of caesareans, indications of induction of labor, is to try and achieve a balance between these two extremes. Otherwise, we're not going to get any further. The principles of an ideal classification, it's got to be very simple. Otherwise, people won't use it. It's got to be easy to implement. It's got to be informative. It needs to be an overview, not the end point itself. So if you like, the more divisions you have at the horizontal level at the top of the classification, the more confusing it will be. You've got to limit those number of groups at the top to something that can draw people in, and then they can develop it within a pyramid, if you like, vertically, more subjective detail. It's got to be robust. There's no point having a classification which is going to change every year. It's ideally got to be self-validating. So if you use some criteria for the classification which are very consistent, in our case, the number of breaches or the number of twins, it's a very useful way of self-validating the data quality. It's got to be universal, a classification. And very personal to me is that it should be able to be used by everybody and understood by everybody, including, importantly, the women that it's supposed to benefit. It's got to be prospective, ideal classification, because then you can go back and change things in the groups that you can identify. And that comes back to the prospective information structure that I talked about. It's got to be clinically relevant, identifiable, totally accountable for all deliveries. Everybody should be classified into one. And it should be replicable, so everybody who uses the classification will use it in the same way. The groups that you decide on must be objectively, not subjectively defined, especially at the top of the classification system. As you go down within the pyramid and you get lower and lower from a vertical point of view and more detail into a particular group, then you can bring subjectivity into it, i.e. the definitions for or indications for caesarean section, for example. The groups have to be mutually exclusive and totally inclusive, and a limited number, as I've said before, at the top of the hierarchy. And remove all the variables, the things that we can't agree on. A classification must not depend on a typical or a particular type of management. You've got to take those variables out, but interpret accordingly. So for the 10 groups, we've used the previous obstetric record, category of pregnancy, course, and gestation. So a woman is either nulliparous, multiparous without a scar, multiparous with at least one scar, may have 2, 3 caesarean section scars, may even have vaginal deliveries. This is prospective, it's simple, it's clinically relevant, and mutually exclusive and totally inclusive. The category of the pregnancy is a mixture of the number of babies and the presentation and the lie. So every pregnancy is either single cephalic, single breech, a multiple pregnancy, or single transverse or oblique lie. And the pathway to delivery is this concept that every woman can only deliver by one of these three pathways. She may go into spontaneous labor and deliver. She may be induced and she may deliver somehow. And then she may have a pre-labor cesarean section, but it must be one of those pathways. And that, again, together with the gestation, makes up the concepts which identifies the 10 groups. And the whole philosophy of the 10 groups is based on a clarity of thought, a structure, a discipline. It's really a common language to bring everybody together, which will stimulate interest, discussion, even arguments. But most importantly, encourages long-term commitment and responsibility. And it's very inclusive to those at the front line. Evidence-based medicine can become very exclusive because everybody complicates it so much. The 10 groups is very simple and very inclusive. And it's based on the premise that all information, whatever it is, will be far more clinically relevant by stratifying them using the 10 groups and their subgroups. And no perinatal event or outcome, including and especially cesarean, should be ever considered in isolation from other events, outcomes, and organizational issues. And therefore, consequently, with good standardization and classification, any differences in either the size of the groups or events and outcomes in the groups are either due to data quality, differences in significant epidemiological factors, or differences in practice. But data quality must always assume to be the most likely reason. And the validation of the data quality and clinical interpretation is possible because of the very homogeneous nature of the groups and because of the consistency of the size of the groups. And they may vary in different populations, but therefore you've got to look for a reason why they vary and explain it. There are unique data sets, especially as we use it more and more in different populations for all kinds of reasons. So there's no wrong or right. And I think it's the actual detail of process of care that aren't what I believe will define us as midwives and obstetricians. It's not that is necessarily the most important thing, but the standardization of information collection on events and outcomes surrounding labor and delivery. They will define us. And that is the more important thing in terms of learning how we do. And gradually the care will come closer and closer together. So really what I'm saying is we should embrace different ways of care rather than separating them out. And we should embrace different ways of care rather than saying there's a standard way of doing things. And we should, instead of concentrating on standardizing processes, maybe standardize the way we carry out our perinatal audit. So greater learning and comparison can take place. And the processes will gradually come closer and closer together, but in a far more natural way. And these are just some papers, very short papers that are worth reading, but it actually emphasizes there in red. It's not just a classification of cesarean sections, it's a perinatal classification system. And it's merely a beginning, not an end in itself. It's an initial overview of the 10 groups, and that's what's important to remember. Now, when you start to present your data and you're looking at cesarean sections, I emphasize, why can't we agree a standard presentation table and slide? And it should be used everywhere, in every paper, and nobody should design their own table because otherwise it's confusing to people who want to look at it. 10 groups have come. Why 10 groups? Well, you want enough groups to show the variance and make them homogeneous, but not too many, otherwise you won't remember them. I haven't got time to go into these in detail, and that maybe come up in questions, but there are a lot of papers. But I just want to emphasize that the groups have been very carefully chosen. The order in the table has been very carefully chosen. Why not more subgroups? People have asked. Well, sometimes when you have more, you get less information. Less is sometimes more in communicating information, and more is sometimes less. It is totally inclusive and mutually exclusive. And at the bottom there, not as a separate group, but any data that's been unable to be classified is there. So the standard way you look at the data, and this is our data from 2022, you look at the number of sections of the total number of deliveries, and they should all add up to the total. You then have the next column, which is the size of the group, which you take the denominator of each group over the total denominator, and that gives you the size of the group. And you should never, ever, ever look at anything else in the table before you looked at the size of the group, especially the cesarean section rates. Many people don't even publish the size of the groups, but the size of the groups are crucial to fully understand it. Indeed, they're crucial to fully validate the information. And these are just some numbers to explain what we've expected in the past and how things have obviously changed once you look at your own groups. But they're just starting points, really, to, if you like, raise the questions that that need answering. And you can see there at the top, the bigger groups are at the top and the smaller groups are down below. You look at the section rate within the groups, and you can see in this unit, they've got a high section rate, but the section rate in group 1 and group 3 are low for spontaneous labor, and all the other groups are quite high. And on the right-hand side, again, some percentages which are there to be discussed, but they're not right or wrong if you're outside those, but what you do need to, or what I advise, is that you find an explanation for it. Now, lastly, the last column is you take the number of sections over the total number of deliveries, and that will give you the contribution of each group to the overall section rate. And that depends obviously on the size of the group, but also the section group within the group. I do advise using the absolute contribution, and I advise it's unnecessary, sometimes confusing, using the relative contribution of the different groups to the high section rate. The absolute contribution is what you should stick with, and especially when you use them together, it becomes very confusing. So the 3 groups that contribute most to the section rates are groups 1, 2, and 5. And these smaller groups, although they've got very high section rates, even if you section them all, would contribute very little to the overall section rate. And indeed, when you think about it and look at all of the other 10 groups elsewhere in the world, they are very, very similar in size. Where the section rate varies a lot is between groups 1, 2, 3, and 4, and 5 for different reasons. So the 10-group classification classifies all events and outcomes within a structure. But most events and outcomes need classification themselves to convert raw data. So once we've got the 10 groups, yes, we look at more detail within the groups, but certain events, such as induction of labor and cesarean section, you need a classification of the indication. I'll mention these very briefly, but it's important to understand the 10 groups is only the beginning. It brings people together. Many people criticize the 10 groups because it hasn't got this, it hasn't got that, but they don't actually understand what the purpose was. And a continual explanation or workshop is needed. But others, such as postpartum hemorrhage, age, and body mass index, need classifying as well to understand the impact they may have on perinatal outcome. And the 10 groups is very important because you could look at the 10 groups according to age, according to body mass index, according to a medical condition such as gestational diabetes or anything you want. The 10 groups tells you in which women inductions of labor and cesarean sections are carried out, but not why the induction or cesarean section is carried out. And this is really important to understand. And there's no accepted classification for indications of induction of labor or cesarean section. This results in a lot of confusion and no common language for comparison and understanding. Now, I'm going to very briefly talk to you about the classification of indications to make it simple. We just have 7: fetal, maternal, medical, pains not in labor, pre-labor SRM, preeclampsia, hypertension, post-dates, post-term, and maternal request. And within all of those compartments, we have more detail on the different detail within those. But if you just had the incidence according to that, that would be very useful. And importantly, too, in terms of the incidence, you need to make sure that the denominator in those are appropriate. So either single cephalic nullips or single cephalic multips. Okay. Now, from the cesarean section point of view, the biggest criticism we would face in the future is not that the cesarean section rate was allowed to increase, but that we made no effort to study it or its implications scientifically. And that's perinatal audit, and that's what I've been talking about. And the first statement to say about indications for cesareans, we need separate classifications for pre-labor, elective or emergency, and spontaneous or induced labor. I believe that this is important. If you look at our own figures here, you can see that of the 34% total cesarean section rate, 2/3 was before labor. So any changes to labor won't make any difference, or very little difference. And indeed, if you look there, spontaneous labor makes the smallest contribution. It's induced labor, and usually why we induce or how we induce may make a difference to that. So we have to differentiate between pre-labor and after spontaneous induced labor. And indications for pre-labor, I think they should be at the high level, as I've described to you before, should be divided into fetal, maternal, or maternal request. They're the three fundamental pillars. Now, I accept that some women may be delivered by cesarean section for fetal and maternal reasons, but we have to classify, we have to organize it according to the main one. And then you can add secondary indications or other detail within it. But we have to, in any given situation, be able to define according to us or the decision maker which group it is in. And I wouldn't worry that, you know, we don't always use the same definition or have different criteria, because that will come out when you look at the results and how you interpret fetal indication. We don't agree on anything about cesarean sections, but let's agree, at least in concept-wise, that the main reason we did the cesarean was either fetal or maternal, even if we disagree with a colleague. But those are our results, and that's why we did it. And I think this is a very important concept. As far as spontaneous or induced labor, we especially need a classification here. It needs to be objective. Oxytocin needs to be a part of it. And the classification must be able to be used however you manage labor. Really important. And the three questions that may help us is the indication for cesarean fetal, but no oxytocin, or something we call dystocia? What were the dynamics of the labor, and was oxytocin used? And again, I haven't got time to talk to you about this, but once you've started learning using the 10 groups, this is what you'd be looking to using after that to find out why this cesarean section was carried out. So it's a classification of cesareans, intrapartum cesareans, and it really actually divides it at the top into two. A fetal indication, whatever your definition is, but most importantly, you didn't use oxytocin, or something you call dystocia. Dystocia is divided into two different types of dystocia. Slow progress, less than 1 centimeter an hour, purely an arbitrary definition or cutoff, and we call this inefficient uterine action, or efficient uterine action, where progress from the time of the commencement of the partiogram to either the time of cesarean section or the time you reach full dilatation, it was greater or equal to 1 centimeter an hour. This one is called efficient uterine action, and probably synonymous with the secondary arrest. Within inefficient uterine action, there's 4 different parts to this. There's the woman that comes in, poor progress, according to your guideline, gets treated with oxytocin, but no progress. Baby is fine, but it still remains less than 1 centimeter an hour. That's inefficient uterine action, poor response. You may give oxytocin to treat the poor progress, according to your guidelines, but the baby's fine, but you're unable to get it up to the maximum concentration of your protocol because the uterus overcontracts. And because you've got very strict guidelines for overcontracting of the uterus, you actually keep it at the safe level, and in the end you give up and you deliver by cesarean. Likewise, you may be unable to give the oxytocin to accelerate labor after a diagnosis of poor progress because the baby doesn't tolerate it. So you keep it at the safest dose according to your regimen, and the baby is fine, not having reached the maximum dose. And if there's no progress and it's still less than 1 centimeter an hour, it gets defined as inefficient uterine action, inability to treat fetal intolerance. And then lastly, there may be some women that progress very slowly in labor, poor progress, but you don't give oxytocin to clinically, and that's in a woman, for example, with a previous cesarean section scar. You may allow her to labor, but you don't give oxytocin to accelerate, and you deliver by cesarean section. And here is just efficient uterine action where there is no other reason for a cesarean section, apart from persistent malposition or CPD. And this classification may take a little bit more explanation and understanding, but I think you'll find it very useful. But when you apply this classification to the different groups, look at the different, and these colors represent the different divisions of the classification. In group 1, you've got a section rate 10%, and there's a different distribution to the relative indication for cesarean section compared with 2A, which is induced nullips, compared with group 3, which is spontaneous multips, group 4A, which is induced multips, and women with a previous cesarean section scar. It's quite dramatic. And the consistency and the difference probably supports the fact that this is a classification worth looking at, and it's one we will be publishing hopefully shortly. Maternal request, I do think we need to think about this. My definition for that is at the time of the request by the woman, in the opinion of the obstetrician, there's a greater relative risk of a significant adverse outcome to mother or baby by carrying out a cesarean section than awaiting spontaneous labor and delivery or inducing labor. Now, this will undoubtedly differ between different clinicians, and that doesn't matter, but record it as maternal request if that's what you believe. The best example, I think, is a woman with a previous scar at 39 weeks. Unless there's another clinical indication to deliver the woman, and I would agree that sectioning her probably would be better rather than inducing her, then I think that is maternal request. But if the woman gets to 41 weeks and it's very unfavorable still, or 40 weeks, and you've run out of time, then I think it's a medical indication. So it depends on the gestation, it depends on the particular group. But most importantly, it's important to remember that maternal requests can occur in any of the 10 groups, and indeed to a certain extent in any of the subdivisions of the classification after spontaneous or induced labor. It's important to remember, I think, that women will always in their own minds choose the type of delivery that seems safest for them and their babies. And if women choose a type of delivery that we disagree with, then either they may be right and we may be wrong, or that the care that is being provided is not what we think it is, or appropriate information is not available. I think this is a strong thing to understand. So if you're going to implement this philosophy, you need the 10 groups, you need the case mix with all the significant epidemiological factors, you need to classify the age and the BMI, you need all the perinatal events or outcome, as well as classification of indications for induction of labor. So these are all your results. You may not be able to collect these all at once. So start with the 10 groups, then the case mix, then the perinatal events. And then when you have those objective results, according to the indications we have talked about, then at the same time, have a list of all of your processes, how you prepare antenatally, what your philosophy is on pre-labor section and maternal request, when you induce labor, how you induce labor, the diagnosis of labor, are all your processes and procedures. Have them as a separate list so that you can interpret your objective results by the first 3 information items there and compare them with others who have different processes and procedures. I don't think the 10 groups will reach its full potential until everybody understands it, and in particular, governments understand it and support it and realize what its true potential may be. At the moment, it's not being used anywhere in the world to near its full potential. It will be useful in interpreting large observational studies and randomized controlled trial results. And this concept of the intention to treat for observational data has been one well established for RCTs. And for this to succeed, you need to prospectively identify groups of women, which you can look at longitudinally throughout the pregnancy, according to different philosophies of care. And the 10 groups allows you that because it's a prospective structure that you can do that. And you treat it according to your processes, and that's the intention to treat. And the original cohort of patient may be your hospital population, it may be a group practice, an individual's practice, or a specifically predefined group of women, either by age or body mass index, or indeed any case mix like infertility problems or gestational diabetes or anything you want to identify. It'll inform you on the makeup of your original population and also the individual groups of women within the 10 groups. And lastly, I want to finish off with this irony that in low and middle income countries, there's no electronic tool at all to carry out structured perinatal audit, while in high income countries, the electronic health records have become so complex that again, it's very difficult to carry out structured perinatal audit. Basically, we should be critical of ourselves that we're not able to carry out this philosophy about the 10-group classification because we're not able to collect the information and make it easily available. And as I've explained here, there are different reasons, different countries why that's not possible. In the low-income countries, you've got no electronic tool, and the high-income countries, you've got such a complex and difficult to use tool that you still don't get information. Please look at this link, register the link, and then log in and try and use it. It is a freely available online retrospective audit system based on the 10 groups, which is designed by myself and my colleague Keith Parker, who's a computer designer, and we hope that people will use it. Indeed, some high-income countries have found it possibly a benefit to them where they feed the information down. This is the data entry sheet. I can't go through it, I haven't got time. You end up with this very simple partogram. You can do a report by selecting the dates very easily. You can modify the search by BMI, by group, or whatever you want to do. And you'll end up getting an overview of all the pregnancies, the previous obstetric history, pathway to delivery, but you'll also get the 10 groups. And what's really exciting about the 10 groups is that you can pop that plus sign and it will bring you with all the individual events that occurred in labor as a big list. You can pop that one there, the 6 dots on the side, and it will give you the individual labors. So if you select a group, you press that, it'll give you the individual labors. You press on that blue thing there, and you'll get that particular labor, and you'll be able to analyze it. So you'll be able to analyze it in terms of tables and results, and also individual cases. This is truly a philosophy of care for everyone. We've got 75 countries with publications. Much more than 100 countries are using it but haven't published. Every speciality has been involved, not only in publications and journals, but anaesthetists are using it. Neonatal clinicians are using it. Midwives have got PhDs and MDs from it, studying the 10 groups. And women themselves, most importantly, are beginning to Google and understand the concept and are beginning to ask questions of their carers. Eventually, governments are now beginning to become interested. And that's hopefully what will change things, because we need workshops to explain it. And I do feel that the biggest advance in 21st century perinatal care to the mother baby is going to be as a result of better routine structured data collection, more sophisticated analysis, and improved implementation of appropriate changes, which may be different on different circumstances. But we are able to learn from each other, which is the most important thing. So hopefully that will be useful, but it's only the beginning of your interest in this. And you've got my email there. I'm very happy in the future to help you with anything you would like, or indeed through the WHO, who have now developed a platform, a manual, and many other resources and facilities to help you. Thank you very much, and I'll be here for questions.